In Chapter 5, we got to see how the innate immune system interacts with the adaptive immune system in order to kick off that very specific response that we need to clear a pathogen. In Chapter 6, we're going to take a look at a more specific response where the B cells and T cells actually become activated toward a specific pathogen. More specifically, we're going to take a look at what happens after the antigen is processed and presented to a T cell, which we talked about in the last chapter. This sort of initiates this adaptive immune response, and as we mentioned in Chapter 5, these interactions occur within the secondary lymphoid tissue so that the B cells and T cells don't have the impossible task of running all over the body trying to find all of the different things that we may have been exposed to. The entire purpose of these interactions within the secondary lymphoid tissues are to generate effector cells, which are ultimately going to help us eliminate the infection. In Chapter 5, we started this figure looking at the acute inflammatory response in a tissue where a microbe enters the tissue. We started the discussion about dendritic cells and other APCs moving from that area of acute inflammation and now focusing their efforts within the secondary lymphoid tissue. In this chapter, we're really going to sort of expand on the events that are occurring within these secondary lymphoid organs, like the lymph nodes and the spleen. What we hope to happen during an immune response is after the initial immune cell activation is to generate very specific effector lymphocytes that can leave the secondary lymphoid tissue, get back into circulation, and we're going to follow this blue line. Where do we think those effector cells are going to go? Well, if there's anything left in the tissue, those effector cells are going to get there because remember, there's an inflammatory response happening and they're getting chemotaxed to that area. Those specific cells can then clean up anything that the innate immune response couldn't handle on its own. Keep in mind, when we're talking about effector lymphocytes, we're talking about lymphocytes that have a specific effect. So it's going to be important for you to know and to think about as Dr. Ali sort of takes you through this chapter that an effector B cell is a plasma cell. So that's the cell that has the effect. If we're talking about a cytotoxic T cell, that effect's pretty easy. It's just going to lyse and kill infected cells. And if we're talking about an effector T helper cell, we're talking about a cell that really has complete control of the immune system through the production of cytokines. And Dr. Ali is going to sort of take you through the development of those T helper subsets.
Ah, yes, Dr. Moscatello working her magic and setting me up so wonderfully. The rest of this chapter is going to be geared at the activation of our lymphocytes, our T and our B lymphocytes. We're going to go ahead and start with our T lymphocytes because really when it comes down to it, the rest of the adaptive immune system is dependent upon the activation of our T cells, these high-maintenance little boys and girls. So when we are talking about the activation of our T lymphocytes, please remind yourself where this is going to occur. And again, it's going to occur within the secondary lymphoid tissues. And if you're looking specifically at the lymph node, remind yourself that the activation of our T cells is going to occur within the paracortex and the spleen within the pals. Again, always something good to remind yourself of. So what other cells are in that area of the paracortex or the pals? Well, our professional APCs are going to be hanging out there, our dendritic cells, our macrophage, and in the neighborhood right next door, we have those B cells. So there are many opportunities for our professional APCs to present peptide to our T cells that are traveling through the various secondary lymphoid tissues. Now, what is it that the T cell is looking for? Well, the T cell is going to require several signals in order to become activated. At the minimum, the T cell must recognize its specific peptide presented by MHC. That's our signal that will start the process. Now, that in and of itself is never going to be enough to activate a T cell. And you should say, well, why isn't that enough? Well, what if it was a self-peptide that was being presented? Would we want to activate those T cells? The answer is no. So we sort of have some safety nets that are going to be there. The most important is going to be the secondary signal that is going to be required to really start activation on. So we have our primary signal through the T cell receptor binding to the peptide MHC complex. Then we have our secondary or co-stimulatory signal. And this is going to be through the expression of B7 on the antigen presenting cells. And here's where things just get really ugly. There's two forms of B7, B7-1 and B7-2, and hey, let's just make it even more complicated, and we're going to give them an alias, okay? B7-1 is referred to as a CD80. We all love our CD markers, and B7-2 is our CD86. Unfortunately, I'm starting to see some questions on QBanks that use the CD80, CD86 rather than the B7. So it'd probably be good for you to know both of those. So again, those are the co-stimulatory molecules that are going to bind to what I refer to as the on switch on our T cells, which is the CD28. And that will provide the secondary signal to begin activation. Well, activation will not be complete until you have the influence of the cytokines that were produced in response to the infection. So really, these cytokines are going to help cause proliferation of the cells upon activation and ultimately will drive their differentiation down the different T cell pathways. This wonderfully busy figure is going to provide you with a lot of information that you're going to need to know, but we've already talked about some of this. First and foremost, just orient yourself to the figure. I have a T cell, and it is a CD4 positive T cell, and it is interacting with the macrophage, which again is one of our professional APCs. Now here, our primary signal, again, primary signal never changes. It's the interaction of the T cell receptor with its specific peptide that is being presented here in an MHC class 2. Notice a couple things that are associated with the T cell receptor, just to be complete. We have our signal transduction complex, the CD3, and also we're going to have our co-receptor CD4, which is essentially going to help stabilize the interaction between the T cell receptor and the MHC. So all of that, that's our primary signal. Our secondary signal is seen over here. Recall we have the B7 that is going to be present on the antigen presenting cells interacting with the CD28, which is our on signal. Finally, we talked about our cytokines. And depending again on what the pathogen is, we're going to have some variation of the cytokines. But in general, you will always see IL-1, IL-6, and TNF-alpha. And in this case, we see the cytokine IL-12. Well, Dr. Moscatello has talked to you about IL-12 on multiple occasions with regards to the activation of natural killer cells. Here, though, IL-12 is going to influence the differentiation of the CD4 cell into a specific subset, which we'll get to in a little bit, but it's specifically going to drive differentiation down the Th1 pathway. So obviously, this is an example of only activation of our T cells that will be involved in cell-mediated immunity. Now, that obviously does not show everything that is on this slide, so let's talk about what else is here. I want to point out to you this molecule, the CTLA4. It looks almost structurally identical to the CD28. As a matter of fact, it is structurally identical, except its effect is different. The CTLA4 is the off switch for a T cell. And you're probably saying, well, why do you have an on switch and an off switch? Well, T cells, again, are very cognizant that the minute they become activated, that there has to be a mechanism to turn themselves off. The CTLA4 will preferentially bind to the B7 over CD8 at the end of an adaptive immune response. Why? Again, we want to turn it off at some time frame. This is now one of the most important pharmaceutical targets when we are dealing with treatment for cancer, as well as treatment for autoimmune disease. So we'll spend a little more time talking about CTLA4 over the next few slides. Now, a couple other things we need to talk about. I don't want you to get too caught up on this, but always remember that whenever I have an interaction between two cells that's going to have to be sustained for an extended period of time, you are going to need the presence of cell adhesion molecules. And that's simply just to keep the two cells held together. It's going to take several days for a T cell to become fully activated and differentiate. So you will see lots of integrin and Ig-like cell adhesion molecule interactions. Now, here's where we're going to sort of pick up. What happens when we activate our helper T cells? Well, one of the things that the T cell is going to do, just like every other activated immune cell, is it's going to start producing its own set of cytokines. And one of the first cytokines that it's going to produce is going to be IL-2. IL-2 is an autocrine. And so you should immediately say, okay, well, an autocrine is going to be a signal that is produced by a cell and acts on the same subset of cells. So IL-2, I will tell you, IL-2 is the one cytokine that I expect you personally to never forget. When I am 85 years old with my walker, dragging Dr. Moscatello behind me, I'm going to show up at your front door and I'm going to knock. And the only thing I'm going to ask you is, what does IL-2 do? And you are going to be very quick in responding that IL-2 causes increased proliferation of T cells. Again, this is probably one of the most important cytokines to date. Now, in order for the IL-2 to work so well, the T cell also has to upregulate a high affinity IL-2 receptor. And that really will help amplify the proliferation of the T cells. So we have our IL-2 being produced as well as the high affinity IL-2 receptor. So the first part of activation is going to result in increased number of my T cells. Since this particular T cell has been defined as a Th1 cell, the other important cytokine it is going to produce is going to be interferon gamma. And that interferon gamma is going to cause several different cells to change their behaviors. And one of the very important things that it does is it works upon macrophage. And I remember Dr. Moscatello talking to you about this, how you can actually take a mild-mannered antigen-presenting cell like a macrophage, give it a little interferon gamma, it turns into a raging killer. So again, all of this is going to lead to enhanced cell-mediated immunity. Now, I will point this out because this is going to be sort of important when Dr. Moscatello talks about B-cell activation. The last part that is going to show up here is that the helper T cell is going to start increasing its expression of CD40 ligand on its surface. A mature naive T cell does not express CD40 ligand. And it's going to be that CD40 ligand that will interact with CD40. So again, just sort of keep that in the back of your mind. Dr. Moscatello is going to go through the import of that particular signaling pathway. Let's spend a little more time getting to know our CTLA4. And this time that we spend is going to be well spent because this is one of the more important immunoregulatory molecules in the adaptive immune response. I've already spoken to you that CTLA-4 is going to be increased in expression on our helper T cells, especially when we get close to the end of our response. You have to be able to turn off these helper T cells in order to contain the number of cells in the body. You will also find CTLA-4 on our regulatory T cells, and this is part of how we contain our self-reactive cells that have made it out into the periphery. So remember, our regulatory T cells are going to be involved in peripheral tolerance. Now, the CTLA-4 essentially competes with the CD28 for binding on the B7. Please recall, though, the different names for B7. I know I keep stressing that, but I would hate for you to miss a question because you don't remember. So B7 is in two flavors, the 1 and the 2, or it is called CD80 or CD86. Now, one of the reasons that we want you to be familiar with CTLA-4 is it's becoming a huge pharmaceutical target. And if you think about it, CTLA-4 is essentially going to turn off T cells. Maybe it would be a great way to target an autoimmune response, because remember, with autoimmune disease, our concern is that unregulated inflammation. So if you can turn off a T cell, you can blunt that response. So you can directly target the CTLA-4. Now, what about the opposite situation? What if you had a situation where you needed the activity of your T cells? You did not want them to turn off. There are pharmaceutical agents that turn off the off switch. What happens when you turn off an off switch? You keep it turned on. Here's a nice table that shows you the different effects of targeting CTLA-4. If you have a drug that works as an agonist, that is going to maintain the off signal of the CTLA-4. And we have several drugs that are now being used not only in autoimmune diseases like rheumatoid arthritis, but also utilizing this target in transplantation. On the opposite side of this, we have treatments that are actually going to antagonize CTLA-4 or, once again, turn off the off switch. If you turn off the off switch, you essentially keep the activation going. And we have several drugs that are being examined currently in different clinical trials, and one approved for use in melanoma. Well, what about the activation of our CD8 positive T cells? Is it really that much different than the CD4 cell activation? And truthfully, it's not. The CD8 positive T cells are going to require that primary signal with the T cell receptor binding to the specific peptide, and in the case here, to the MHC class 1. And they are also going to require the co-stimulatory or secondary signal through B7 and CD28. But one thing that is an exception with CD8 positive T cells is that unlike their CD4 counterparts, they really don't secrete very high levels of IL-2, which means that they sort of have a blunted proliferation. So the helper cells now help these CD8 positive T cells become fully activated by providing them with very high levels of IL-2. So this is sort of a point that we need to make so you understand why a T helper cell helps a CD8 positive T cell. Well, since things are going so smoothly with immunology, I thought we'd drag in a little microbiology right now. There is a high-yield topic that is going to talk about this non-specific activation of T cells, and this is through a series of either viral or bacterial proteins known as superantigens. Well, how superantigens work is that they are going to cross-link the T cell receptor to an MHC class II, regardless of specificity for the peptide. So again, this is a non-specific interaction. What is going to occur is that you're going to end up having polyclonal activation of your T lymphocytes. Again, it is going to be a non-specific activation. This is going to essentially result in increased levels of interferon gamma production. Wow, that's a very important inflammatory mediator. And remember that interferon gamma is going to act on cells like macrophage, and it's going to hyperactivate my macrophage, and my macrophage in turn are going to say, yes! Here's more pro-inflammatory cytokines like IL-1, IL-6, and TNF-alpha, which is only going to further amplify the response. And in the end, what you're going to see is a systemic toxicity due to the overproduction of these pro-inflammatory cytokines. With regards to the different superantigens that are going to be tested on the step 1, there really is one that you need to know out of all of them, and that's going to be the toxic shock syndrome toxin 1. Now, with that said, do I guarantee you will not see other superantigens tested on? No, but more often than not, they are going to set you up with a beautiful clinical vignette. And surprisingly, most of you are probably going to be thinking you have a presentation of a young female who is menstruating, and they'll throw something in about her failure to regularly change out her tampons. That was a great classic presentation of toxic shock syndrome. I want you to be aware, though, the fact that I'm seeing more and more Q-Bank questions about an older male who is post-op that is showing up febrile with desquamation of his palms and his soles. And what has happened is that he has gotten toxic shock syndrome from a staph infection of his surgical packing. So please beware and recognize that males and females can both get toxic shock syndrome. A couple other examples of superantigens are our strep pyogenes exotoxin and some of the other staph enterotoxins. The figure shown illustrates that interaction of the superantigen, essentially cross-linking the T cell receptor to the MHC class II. If you look at the figure, you will notice that there is no complementary binding between the T cell receptor and the peptide. It is a nonspecific interaction. But this is such a strong bond between the T cell receptor and the MHC class II that even in the absence of a co-stimulatory molecule, you're going to get activation of the helper T cell.